Hey, good morning and welcome to UroNurse. I'm your host, Vic Sinise. Welcome to the show. We come to you live every week at 9 a.m. Central Time on all of those different channels. If you're watching us for the first time, check out our website at uronurse.com. Best place to go to learn more about the show. Also, the best place to go to learn about any of our previous episodes. You can find all of them up on our website. If you want to listen to your car, no problemo. You can check us out. We put out an audio version of every episode later on in the day. And if you subscribe through podcasts, Spotify, iHeart Podcasts, Amazon Music, or YouTube Music, you'll be able to have that automatically sent to your mailbox and listen in your car. So this week, we're going to have a one contact hour program, new therapies across the spectrum of prostate cancer. And it's what urology nurses and advanced practice providers need to know. It's really an interesting subject, but it's a long show. It's going to be a 1 hour show. So we're going to scoot right along and bring that up for you. We won't be doing any Q&A at the end of this, so not to worry. You'll have plenty of questions answered throughout the show, but it's just the nature of the beast when it's a long show. So let's get going.
Now, my privilege to turn things over to Dr. Vaishampayan to get us started on this CE symposium. Thank you.
Hi, good morning, everyone. And it's a pleasure to be here. Thank you for joining us bright and early. Hopefully the breakfast is worth it, but we will definitely make it worth your while. So I'm glad I'm joined by Grace today. Grace has worked for a long time at the VA and has tremendous experience working with prostate cancer patients. And we're going to be talking about the results of the key clinical trials that show the efficacy and safety of new and emerging agents in the treatment of advanced prostate cancer. We're going to be talking about different strategies to optimize the treatment, because for prostate cancer, typically, you don't just do treatment for a short time and stop. You know, there is a prolonged period of time that your patients are going to be on treatment. So keeping them, maintaining them on the treatment, optimizing the treatment is really a big, part of the treatment strategy. And then talk about the role of nurses and advanced practice providers in improving prostate cancer management. And like I said, because you're in it for the long haul, there is a lot of patient interaction, and along the way, you have to customize the treatment sometimes to their needs. So nursing considerations in managing prostate cancer. We'll be talking about what prostate cancer looks like, the overview of the disease state, and some key clinical evidence, and we're going to show it with patient cases. So you sort of can put it in perspective to an actual patient that you might be seeing in your clinic and having to make treatment decisions on. So we will talk about nonmetastatic castrate-sensitive prostate cancer, which is a very common patient in urology clinics, PSA relapse after surgery or even after radiation, etc. And then we'll be talking about metastatic disease, because as these patients get metastases, they are still typically being seen in a urology office. We'll talk about castrate-resistant prostate cancer, non-metastatic, which means when they've started to have their PSA start going up, even after they've been on hormone therapy. And then we'll be talking about metastatic castrate-resistant prostate cancer, one of the biggest challenges in advanced prostate cancer treatment. And we'll talk about how that multidisciplinary collaboration should work. So starting with an epidemiology, prostate cancer is the most common disease in American men, most common cancer. About 30% of new cancer cases in men are prostate cancer. So what we saw from the prostate cancer prevention trial is that if you biopsy and do screening procedures, 1 in 4 men will be diagnosed with prostate cancer. If they're about the age of 50, you're doing an annual PSA. Now, within that, there are about half of them are clinically relevant prostate cancers, which means they need treatment. They're likely to go on to get metastases in the patient's lifetime. Now, in African Americans, there is a much higher incidence. So I would say about twofold increased incidence in African Americans as compared to the average other Americans with prostate cancer, and there has been a higher mortality seen. But what we do know now more and more, that if they get access to the right treatment, their survival and their overall outcome can be the exact same as any other person with prostate cancer. Median age, this is a disease of the elderly. Median age at diagnosis is about 68. And clearly, we all have those patients in our clinic, 80 plus, 90 plus, who have prostate cancer. And they raise a separate dilemma because you're always wondering about the risk-benefit ratio of different treatments in them. 11% of estimated cancer deaths in men are from prostate cancer, so don't let anybody tell you that prostate cancer does not kill. It sure does. Metastatic castrate-resistant prostate cancer can be a very morbid condition with the bone pain, with the neuropathic compression, etc., and the possibility, of course, of mortality. So, age incidence, of course, it rises after age 40. Those young patients, you should be specially paying attention to if patients have a family history or if they have history of BRCA1, BRCA2 mutations within their family with breast cancers, ovarian cancer. Frequently, patients will not make the connection. They will never think of telling you that, their mom had prostate cancer or their mom had breast cancer or their sister had ovarian cancer, and, whether that could be genetically connected. Well, it absolutely is. So that is something. I had a patient for years who never told me until I met his daughter she had had a bilateral mastectomy because she had BRCA1 mutation. And, the crazy thing is the patient kept saying, no, I have nobody in the family who has cancer. And so just now it is important in this era of genomics to sort of push a little deeper about the family history. So 5-year survival rate for early localized disease. Clearly, if you find them early enough, long-term, 5 years is sort of a short-term follow-up for prostate cancer. As I said, you're in it for the long haul, but 5-year survival rate is almost 100%, 90% cure rate in those early-stage disease patients, but then 5-year survival rate, once they get metastatic, once they have PSA relapse, rapid PSA doubling times, the rate drops to about 30%. So this is a heterogeneous disease that does require personalized care because you're dealing with an elderly patient population. Frequently, they have multiple other comorbidities that you have to take into account when you're considering treatment. So the heterogeneity of prostate cancer makes the patient management somewhat challenging. There's a wide spectrum. It can go from aggressive to very, very slow growing. Sometimes the slow growing can change, so monitoring is also key. And 30 to 40% of patients, what population studies, SEER data, et cetera, shows us that are not getting optimal treatment, and maybe that's an underestimation, and they are either over or undertreated. So bottom line, improving individualized care in prostate cancer is a big unmet need. Whom to treat, when to treat, and what is the best treatment? Also, I would add to that now how long to treat. If patients, it's a good problem to have because if patients are going to go longer term, even with metastatic disease now, with the better and better treatments we have, maybe we do need to think about, do I stop treatment after 2 years, monitor them closely, select out the patients who we can do that for. So these are the clinical states of prostate cancer. Clearly, the clinically localized disease is where you first typically see the patient, at least in a urology office, where you're biopsying, sending the patients for a biopsy, or the primary care physician has seen that there is an elevated PSA and has referred the patient for consideration of biopsy, etc. Then there is the PSA recurrence. So after you've done surgery or sent the patient for radiation, whatever it may be, if the typical way you're going to monitor this patient is by PSA. And usually after surgery, in prostate cancer, your PSA should be undetectable. However, once it starts going up, there are different pathways of how we tackle those patient population. Then moving on to the non-metastatic and metastatic. Metastatic is where on conventional imaging and not the PSMA PET scan, that is not included so far in our definition of metastatic disease. We talk about if we see mets on a CAT scan or a bone scan, that is to this day at least, considered metastatic prostate cancer. There is a new definition for oligometastatic prostate cancer. So when you have a PSA that is fairly low, 0.5 or higher, usually you would do a PSMA PET scan trying to detect early metastases. And that is if you find 3 to 5 mets or less, is considered oligometastatic state, and that can be handled with stereotactic radiation, very focused radiation to those areas, things like that. So that is the nuance of this new state that is evolving. Unfortunately, what we don't have is long-term follow-up for this. PSMA PET scan and all that has been probably available for the last 2 to 3 years. So these are the different clinical states and the definitions, and you have those up there. I won't go through each and every one, but I think bottom line, rising PSA would mean that you need to typically get some imaging. Do not react to just one PSA. If the PSA goes, and patients are tuned into, the moment they see any change in that number, they're like panicking already. And it's your job to sort of reassure them and say, let's not jump to too many conclusions just based on one PSA. At least do one more repeat one like a month or a few weeks later to see where they stand. And if it's truly continuing to rise, then you at least have confirmation and then move on to your workup. So typically the rising PSA pattern will decide, and then you go back and look, was there positive margins? Was there, what their Gleason score was? So that the Gleason score tells us how aggressive the prostate cancer is. And then you make a decision. If it was rapidly aggressive, the PSA is going from 0.1 to 2 to 5 within 3 months, then you have a problem. You usually need systemic therapy, which means like treatment like hormone therapy would be systemic, which goes through all their system and controls the cancer. Versus if it's a slowly rising PSA going from 0.1 to 0.3 in 3 months, and they had a relatively okay lower Gleason score disease, were in remission after surgery for 2 to 3 years, and now they're relapsing, that patient population, then you can think of salvage radiation or salvage options for therapy. So local options, I mean. So all of these states have, even within each of these states for prostate cancer, we can customize the treatment to the patient. Okay, so here is the identification of metastatic disease, and I'm going to show you presence of, as the PSA goes up, you typically would do a PSMA PET scan in today's world. Now, what I will caution you against is doing the PET scan too early and then saying, oh, it's negative, it's not showing us any signs of metastases. Frequently, I find that the PSMA PET scan is done at PSAs of 0.2, 0.3, and the yield of the test at that level is very low. So usually, think of it as a cutoff of 0.5 or higher. And that's where the PSMA PET scan will probably give you the best possible information. Below that, you really don't know if it was just because you did it too soon that the scan didn't detect it, or if it's truly a negative scan. So it has allowed us, though, to do early detection of metastases. And like I said, if you see those limited amounts of metastases, then you are able to consider local therapy, very focused radiation to those areas, and try to get the PSA down and get the patient in remission sometime longer before you need to use hormone therapy. Because androgen deprivation, no matter what, it has a big impact on patients' quality of life. It also, longer term, it has multiple other side effects. Now, it's a very effective treatment, don't get me wrong, and it is important to use it when you need it because, it does make a big impact. It improves survival, improves life expectancy with metastatic and advanced prostate cancer, even PSA relapse prostate cancer. But unless you have a rapidly rising PSA or if you can manage the disease with local therapy for some time longer, delay the time to starting hormone therapy or androgen deprivation therapy, that is still a worthy goal in today's world. So imaging is the mainstay. The RADAR group showed that PSA is the best predictor of metastases. Of course, we all know that. The patients know that. I defined PSA as patient-specific anxiety more than prostate-specific antigen because you get those phone calls all the time. Anybody who's worked in prostate cancer world knows that, patients or their provider or their wives or family members are calling, oh my God, PSA went up from 0.1 to 0.2 or whatever it may be. So that is obviously something you have to take into account. There are some situations where the PSA is not a good indicator, and we'll talk about that as we go on to, talk about really widespread metastatic disease. So what this picture is showing you is the scan is showing you where the prostate, that bright area on the, sorry, I can't see if this has a marker, but maybe not. But anyway, so the picture on the picture of the skeleton is showing you areas of uptake, and this is on the PSMA PET scan. There are a couple of bone areas that are showing uptake. But as you can see, on the CAT scan, we don't see that, but the PSMA PET is lighting up. So that's the comparison that we are trying to show here, where your regular CAT scan and bone scan is not quite showing the disease. But when you do the PSMA PET scan, you see the area which is lighting up, like right now in the pelvis, where there is residual disease or relapse disease. Okay, now let's get down to androgen deprivation therapy. And this is a big, big foundational treatment for all stages of prostate cancer, I would say. But definitely for the more advanced or high-risk prostate cancer, you're going to be using this very commonly. Now, the bottom line, what was noted in prostate cancer is that suppressing the testosterone made a big difference to the cancer. In the olden days, when it was first recognized, patients had orchiectomy, and that dramatically turned around their disease course, their symptoms got better, everything improved very rapidly. You can, of course, now most of us do chemical castration with one of the either injections, and there is also an oral medication now that can suppress the testosterone without having to use injections. But bottom line, the whole goal is to suppress the serum testosterone, and the typical goal is less than 50 is considered conventionally castrate levels of testosterone. And ideal, if the lower you can get it, there have been some reports that showed that if you get it less than 20, that actually makes a bigger dent or shows improved outcome. But the first thing you do, so if somebody is progressing on hormone therapy, let's say you have them on an injection for a few years and now the PSA is going up. First thing you do is check their testosterone level. Make sure that the testosterone is still suppressed. Most of the time it will be, and the PSA progression is real. But sometimes you find that your injection hasn't worked as well, or there is a testosterone escape. So then you can you're in a different state of disease where it is still hormone sensitive as compared to labeling the patient castrate resistant. So surgical orchiectomy, anti-androgens. Now, anti-androgens are if you give it by itself, and excuse me. And we have them listed up there: flutamide, bicalutamide, nilutamide. These used to be the olden anti-androgens that we used, and they were used. Now, if you use the anti-androgen by itself, the way it works is it's blocking the androgen receptor. So it stops the receptor, the testosterone, from binding to the receptor on the prostate cancer cells. So that's how it works. So upfront, bicalutamide or something will work very quickly and give you a response, and it does not lower the testosterone level. So if you have a patient who absolutely cannot tolerate lowering the testosterone level, goes into severe depression, I mean, these are occasional cases, thank God, but if they have the severe reaction to suppressing their testosterone, you can consider single agent anti-androgen. And now, of course, we have more effective anti-androgens like enzalutamide, which has shown remarkable activity, better than LHRH analog alone, in fact, in the PSA relapse setting. So here are all the FDA-approved agents for advanced prostate cancer. I don't think you need to know each and every name, but the ones you do need to know are the hormonal agents and the hormonal injections, obviously. You need to know a little bit about chemotherapy as well as PARP inhibitors, just because that is something, the sooner you check for that and do that, and also because chemotherapy is now being incorporated earlier and earlier in the disease. So here are all the different approved agents for the different states of prostate cancer. So for non-metastatic CSPC, so when the patients have that typical PSA relapse, the most common patient in the urology office after upfront diagnoses, is the patient where their PSA is rising, and now you're considering different options. So these are all the different agents that are approved, not chemotherapy in that setting. If you don't have metastatic disease, you usually don't use chemotherapy in today's world. So unless patients have clear metastases on CAT scan or bone scan, you're not going to typically use docetaxel. Radium-223 is an agent that is, again, these are all mCRPC, castrate-resistant patient, where you can use radium to help with bone metastases only. If they also have lymph node metastases, don't bother using radium because it's very much a bone-targeted anti-cancer therapy. PARP inhibitors, if they have BRCA1, BRCA2 mutations, and sometimes you could potentially argue for patients who have family history, who have very high risk locally advanced cancer, so high Gleason score, high whatever, those might be people who you do genomic testing even up front without waiting for them to have metastases. But for the most part, you don't use PARP inhibitors until they have metastatic castrate-resistant prostate cancer. So nursing considerations, non-metastatic hormone-sensitive prostate cancer. We'll start with that, talking about clinical evidence, and this is the non-metastatic, where their PSA is rising, as I said, the most common patient that with established prostate cancer in your clinic that you will see, normal testosterone level, elevated PSA, and usually these patients are not going to have any symptoms because they don't have actual metastatic disease so far, so they're not going to feel any symptoms related to their cancer. And this is, so the PSA can rise, and the definition, as we said, is any detectable post-radical prostatectomy. The PSA, if it is 0.2 or higher, because it should be undetectable, right, if patients have their prostate removed. And then post-RT, the nadir plus 2. So if they started with a PSA of 7, their PSA went down to, let's say, I don't know, 1.8, then you usually add plus 2 to say that, this is truly a relapse, because with radiation therapy, definitive radiation therapy, their PSA is not going to go to undetectable necessarily. Also, PSA bounce is something that is a phenomenon that is sometimes seen post-radiation therapy, where the PSA goes up for a few months and comes down on its own. Nobody knows why that happens, whether it's prostate inflammation or something transient. And that's why that monitoring and, being absolutely certain that confirming that the PSA is rising is of critical importance. So these are the options. If patient's PSA is progressing after radical prostatectomy, then you do radiation if they haven't had radiation before. If they've already had radiation as their primary treatment, or even after salvage, you can look into cryotherapy or HIFU as salvage therapies. Now, these are very specialized. You have to prove that the disease is only in the prostate. If they have 3 other areas that are lighting up on the PSMA PET scan, don't bother doing HIFU or cryotherapy because it causes much more risk of incontinence and local symptoms. And if there's disease already outside the prostate, it may not be worthwhile to do that. For most of the other patients, you're going to consider androgen deprivation therapy, but you have to take into account their cardiac status, their overall disease condition. If they have rapidly progressing disease, honestly, if they have low Gleason score, their PSA is eking very slowly from 0.2 to 0.4 in a year, I probably would just say, you know what, right now, just observing you and not doing any further therapy is probably the better way to go. Is the smarter way to go rather than sticking them on hormone therapy just to see that number go down, and you're committing the patient to a treatment that has long-term issues. I mean, if this patient is going to live 25 years more, you want to be gradual about when you give the therapy, how you give it, and always, if you're considering androgen deprivation therapy at this state, always have a goal of doing intermittent therapy. Because there are studies that have compared continuous versus intermittent. The outcome has been exactly the same, but you can save your patients. They give them that side effect-free period for some time at least. In between, it will help with their cardiac health. It will help with their overall bone health longer term. So that is a critical piece of managing non-metastatic castrate-sensitive disease. So here is the PSA doubling time. Use that. The shorter PSA doubling time has been shown to have higher risk of metastases quicker. So if patients had a PSA doubling time of less than 3 months, almost all of them had obvious metastases within the first year. So that's just something that you can use to sort of risk stratify patients. Post-radiation, the risk factors for metastases are Gleason score. So go back to the original Gleason score always. I, in fact, print a copy of the pathology report because sometimes, 10 years later, you're looking and that hospital has closed or whatever for the path report. So I give my patients a pathology report and say, you need to keep this carefully because you never know when you may need it. And that is a critical piece also. Clinical stage, time to biochemical relapse. So if patients went 5 years before they had a PSA relapse versus somebody who's 6 months later coming to you with a rising PSA, completely different patient population. So, and then of course the PSA doubling time, which is something, there are all kinds of websites or nomograms where you can quickly calculate the PSA doubling time. Reassure patients sometimes that, you know what, your PSA doubling time is 15 months. This is going so slowly, we have time to continue to monitor you and make an intervention as needed. Or if it's going rapidly, then you need to sort of be more aggressive with their management. So intermittent ADT, we discussed that. Absolutely, always consider intermittent. So you stop usually about 6 to 8 months into the treatment. You stop, assuming they got a PSA remission, so PSA is undetectable or less than 0.1, whatever you want to call it. Then you just monitor the patient every 3 months or so, and once their PSA goes back up, you restart and do the whole process again. There will come a time, of course, when they get castrate resistant, where their PSA continues to rise, even if you give them back their LHRH analog. But until then, doing intermittent is absolutely better in terms of improved quality of life, hot flashes, libido, urinary symptoms, fatigue, and as I said, that longer-term cardiac risk, metabolic syndrome risk, and bone health risk is better with this. So here is the study called EMBARK, which was a pretty big advance recently in non-metastatic prostate cancer. So these were all the PSA relapse patients who were randomized to get standard hormone therapy, so your hormone injections, whichever one you use in your office, and as compared to doing enzalutamide by itself, which is an androgen receptor blocker. So as we know, by itself, giving enzalutamide does not suppress the testosterone. So patients don't have the typical hot flashes and fatigue and muscle pain, muscle loss, and all of that you expect from androgen deprivation therapy. And then the third arm was the combination of enzalutamide and LHRH analog. Primary endpoint was metastasis-free survival, as in time to developing metastases, which of course is a critical endpoint. And as you can see, interestingly, the combination did the best. So the combination, when you combine LHRH analog with enzalutamide, that combination performed the best and had the longest period where before patients got metastases. LHRH analog therapy control arm, so you can see the thing there. But what was very interesting is the enzalutamide by itself, where the testosterone was never suppressed. That arm did also much better, significantly better, as compared to LHRH analog alone. So that tells you that you can have the potential for somebody who does not want the combination therapy, who does not want androgen deprivation therapy. You can consider using enzalutamide as a single agent and get prolonged time to metastases with that strategy. Now, again, the one thing to consider here is this was also intermittent therapy, by the way. So patients were treated for 36 weeks, then stopped, assuming they had gone into remission, and then just monitored. When they needed it again, when their PSA came back up, they were again resumed on the whatever arm they were on. So this was also an intermittent therapy regimen that achieved this kind of delayed metastases-free survival. So something to keep in mind. The one thing to remember about enzalutamide, who do you not give enzalutamide to? People with history of seizures or high risk for seizures, head injuries, strokes, recent strokes, already are on anti-seizure medication. Those are patients who were excluded from the study and you avoid giving enzalutamide to. If on enzalutamide your patient gets a seizure, which happens 1 in 1,000 or 2 in 1,000 cases, if that happens, though, stop the enzalutamide and do not re-challenge the patient. So just keep that in mind. I've had patients who've been admitted with seizure while they were traveling from Michigan while they were living in Florida, the 6-month thing in the winter, they come down here. And nobody even made the connection that the patient was on enzalutamide until they came back and saw me in Michigan. And, so that is just something that needs to be stressed and kept in mind. Okay, this is a PRESTO study again in the PSA relapse population looking at apalutamide. So same principle, apalutamide is also an androgen blocker similar to enzalutamide that also has the risk of seizures, etc. So similar type of contraindications exist for apalutamide, and pretty similar data that the combination did better as compared to ADT alone. So you definitely should consider either combination. Single agent LHRH analog therapy is no longer considered standard. Now, which patient population though? These were all patients who had rapid PSA doubling time. So PSA doubling time had to be less than 9 months. So you should not use the intensification of therapy with combination in any patient with PSA relapse, but look at the doubling time. Only the ones with rapid doubling time who are going to get metastatic disease quickly are the ones you want to select out for this intensification. Other nursing conditions for non-metastatic. So I'm going to turn over now to Grace so she can talk about the case, and then we will discuss the next topic after that. Thank you, Grace.
Thank you, Dr. Vaishampayan. Can I get a show of hands? How many of you are from the area? How many had to fly in or drive in the last 2 days? Well, we are happy that you are here and you are safe. We hope your families are safe, and thank you for joining us this morning. So we'll start off with the case. TM is a 72-year-old black male with a biopsy-confirmed recurrence of his prostate cancer. His past medical history is significant for hypertension and mild CKD. He previously underwent RT in 2014, followed by 2 years of ADT. PSA initially was undetectable, but as you can see here, over the course of time, it has gone up with a doubling time of 8 months. His PET scan, PSMA PET, showed an uptake to the prostate gland, and the FNA biopsy of the gland confirmed recurrence. Your tumor board recommends a combination of ADT and enzalutamide at this point. What do you need to know about adverse events management to better counsel your patient? So we're going to go back to that case later on. What we know about ADTs is that they have been associated with cardiovascular risk as well as risk of thromboembolic events. CVD is the most common non-cancer cause of death actually among cancer patients with prostate. Good control of blood pressure, what do we mean by that? What is the goal number? So for the high-risk patients, and your risk factors are advanced age and multiple comorbidities, the numbers you want to look for is a systolic ranging from 120 to 130 and a diastolic of less than 80. Your low-risk patients are the one clearly who are younger, with less comorbidities, and that would be a systolic of 125 to 139 and diastolic of less than 90. And comorbidities we're talking about are your hyperlipidemia, diabetes, and tobacco dependence. For these types of patients, you want to consider trying to not have that echo. You want to consider working with a cardiologist and their primary care provider for optimal maintenance of these conditions. The use of baby aspirin is also known to be helpful and used for patients with cardiovascular diseases, unless it's contraindicated, obviously. EKG monitoring can be considered because it can be associated with QT prolongation for people on ENZA. You also want to avoid ABI, with high risk for CVD diseases and cardiac comorbidities. As far as skeletal health, ADT has been associated with loss of bone density. Bone density screening is recommended at baseline and every 2 years while on treatment. Smoking cessation, decreasing alcohol and caffeine has also been shown to be helpful in minimizing the loss of bone density. And using prophylactic calcium supplements in these doses, as well as vitamin D daily, have also been helpful. Weight-bearing exercises should also be encouraged. Fraction prevention, ADT has been associated with the development of osteoporosis, and how you want to detect that is by using your FRAX tool. So even if osteoporosis is not necessarily shown on your bone density test, there's a calculation you can use. It involves age, use of glucocorticoids, personal history of previous fractures or family history of fractures. Those all get factored into that calculation for people to be put at risk for osteoporosis, and who actually has an algorithm of who should be started on preventive medications or therapeutic medications. And this usually involves your osteoclast inhibitors, which decrease bone turnover and increase bone density. This includes your biphosphonates and denosumab. Other possible side effects of ADT, fatigue is quite common. As you can see, up to 77% of patients may complain of this while on ADT. And what you want to do, which they think is usually, patients would tell you, that doesn't make sense. That's counterintuitive. Why would I exercise more when I'm tired? But it has actually been proven to be the most effective way to battle fatigue. A balanced diet obviously will be helpful too. And perhaps for people with severe fatigue, you might want to consider dose reduction of some of your hormonal agents. I tell patients and providers and trainees, these medications can only work if they are being taken. And if the patient cannot tolerate them, they're not going to be helpful to the patient. Erectile dysfunction can also happen. I work at the VA. I have soldiers, veterans who might have very serious issues with erectile dysfunction and how it might impact their sexual relationship with their partners. I've actually had 1 or 2 patients completely decline treatment for this reason alone. So counsel them that there are things that can be done. You can work closely with urology. There are medications that can be used. Sildenafil is one of those medications. It works using the nitric oxide induction of vasodilation. So be very careful when you have patients also taking nitro at the same time, because that's going to be a double whammy, right? You have two agents potentially inducing vasodilation, thereby leading to hypotension and potentially causing problems for the patient. People who may not want to take medications, there's alternatives as far as a vacuum-assisted erection device that can be used. And the last option is not very popular. It sounds very invasive, and patients usually are turned off by that. They can actually do an intraurethral suppository of the medication, as well as an intrapenile injection. But that's not usually the more popular choices, as you can probably predict. So vasomotor hot flashes is also very, very common. I think this is the most bothersome, most common symptom patients present with. Up to 80% of patients can suffer from this. What usually causes this is a drop in your luteinizing hormone, follicle stimulating hormone, which thereby increases your norepi and results to poor peripheral vasodilation and the poor regulation of the hypothalamus and the brain. I have patients, get some medications for this, but one of the more popular things that I actually learned from a patient, he said his daughter saw it online and bought him one and tried it. It's actually a device that goes around his neck. So it's almost like your headphones, but instead of going around the head, it goes around the neck, and there's a constant fanning event that happens. It operates on batteries, and he swears by it. I've had 2 other patients. He gave me the box. I said, let me make a copy of this, and I have my little education bins in my exam room, so I've had 2 other patients buy the same device, and they swear by it. So how can you manage other advanced events in this setting? So estrogen has been helpful in treating vasomotor symptoms too. This medication, your cytopoietin acetate, has been helpful in treating that condition as well, but you want to be careful because it can also lead to fatigue, gynecomastia, enlargement of the breast. It can be harmful to the liver as well as affect the cholesterol levels as well. Progestin has been helpful also. It works on the luteinizing hormone. MEG-ACE, 20 milligrams BID, has been found to be helpful. Again, it can also cause side effects such as weight gain. And also, it usually is not indicated for patients who have a history of clotting disorder. SNRIs has also been helpful for some patients. Usually, venlafaxine is a medication you can try. We usually start at the lower dose of 37.5, and then you can work your way up. And I tell patients usually give it time. Don't titrate it after 48 or 72 hours. And then your GABA analogs, such as your gabapentin, can be tried too. And you can use it up to a max of 300 milligrams TID. Again, I work my way up with this medication. It can induce drowsiness. So I educate patients when we're going to start low and go slow. Be careful operating equipments when you start on this medication and even while on the medication. And if you intensify treatment, clearly you're likely to intensify the adverse effects too. So be mindful of that. That's what Dr. Vaishampayan was talking about, that single agent ADT is usually not your way to go anymore nowadays, but you want to be mindful of your patient. If you're starting an 80-year-old patient, you might want to rethink that and potentially consider single agent ADT for that population. You also want to consider intermittent treatment, especially if your PSA is down to less than 0.2. And consider resuming when the PSA rises. If they have had RP, then maybe over 2. Again, this is people post-intermittent ADT already. This is not the case we were talking about, that this is their first relapse. And then if no RP, perhaps consider resuming over 5. In the EMBARK trial, about 90% patients had median suspension of about 20 months. So about a year and a half, they did okay before having to go back on treatment. So back to our case of TM. Again, as a reminder, he has been diagnosed with hypertension, mild kidney disease, underwent radiation and 2 years of ADT previously, doubling time of 8 months, with a PSMA PET showing uptake on the gland that was confirmed by biopsy to be a recurrent prostate cancer. What will be your most important consideration when educating him about his hormone therapy? Number 1, do you instruct him to monitor his urinary output for oliguria? instruct him to check his BP at least once a day, instruct him to develop or report development of gynecomastia, or instruct him to seek immediate care for hot flashes. So, okay, there you go. We'll give you time to think about this and hop in your answer. Okay, well, you guys got that right. You want to instruct him to check his BP at least daily. As we have said, ADT has risk for cardiovascular disease development, perhaps aggravate risk factors involved with it. So that's really the most important thing that he should be doing. The rest of them is not necessarily wrong. You still want to know about these things, but are they as immediate and urgent concern for you and the patient as number two? Likely not. All right. I'll turn it back over to Dr. Vaishampayan.
Thanks. And moving on to metastatic castrate-resistant sensitive prostate cancer, so where patients, and 90% of the patients on these studies were the ones who suddenly presented with metastatic disease. Those patients, inpatient consults you see with severe bone pain or cord compression or urinary obstruction with elevated creatinine, and that is their first presentation of prostate cancer. You do a PSA, it's 500. You have to sort of get a biopsy, but also get them started on therapy. So that kind of patient population is, not as common anymore, but we definitely, all of us have seen those patients in the hospital where they suddenly present with this disease. And then the other typical patient is the one who's already had a PSA relapse and gradually develops metastases. Now, that would be a pre-treated patient population versus the other kind may not have been treated ever for their prostate cancer. So here is the different clinical trials, but the bottom line summary of this is now you cannot just use LHRH analog, which is what we used to do. In the hospital, definitely start the patient on single-agent bicalutamide. Once they get discharged, you can follow up with the LHRH analog injection, etc. And then you have to start thinking of adding either apalutamide, enzalutamide, abiraterone, and prednisone. So these are sort of the three typical ones, and the fourth one is darolutamide. So all these four are approved by the FDA in hormone-sensitive metastatic prostate cancer. And then the other aspect to it is chemotherapy with docetaxel. Each of these have provided an incremental median survival benefit of 6 to 8 months. So bottom line, it is important now to intensify therapy, so not just use the LHRH analog anymore for metastatic disease, unless the patient's life expectancy is really 2-3 years and you're really not concerned about the longer term. But you, at a minimum, have to add an oral agent along with it and potentially consider docetaxel chemotherapy. So that is the current management of metastatic hormone-sensitive prostate cancer. And each of these, there are different reasons for that. But docetaxel, usually with high tumor burden, if there is big bulky lymph nodes, if there is visceral disease, for sure you have to use chemotherapy also. In the other average patient with bone metastases who is well controlled, who has a rapid decline in their PSA in the first 3-4 months, their PSA is down to undetectable, even from 400-500 down to undetectable, I would stick with just using the LHRH analog and the combination with one of these oral agents, either abiraterone and prednisone, apalutamide and enzalutamide. And the reason the different mechanisms are given there, abiraterone is different from all the other androgen receptor inhibitors in that abiraterone actually lowers the testosterone even further at the tissue level, at the cancer level. So that is a CYP17 inhibitor. And because of that, the side effects are completely different. This is a summary of all the trials that showed survival benefit. I don't think we need to belabor this, but bottom line, all of these randomized trials are showing that there is a survival benefit to using combination therapy earlier in metastatic disease. Don't wait until they're castrate resistant. Use it up front. It makes a big difference. And it may not make a big difference in the PSA response, by the way. PSA response may be the same with just the injection as compared to the injection and the pills, but the longer-term sustaining of that response is what is better with the combination therapy. So that's just something to keep in mind. Don't just look at the PSA and say, hey, this patient's PSA is undetectable, now I don't have to worry. No, you do need to add the oral agent, thinking about the longer term. And then in low volume, low risk disease, you can consider radiation if the patient truly has achieved that PSA remission, their scans are looking like they have no signs of progression, everything is controlled. Then you can consider and have a discussion with the patient about radiation therapy. So this is the improved overall survival from all these different studies. I'm going to skip through these, but we'll spend a little bit more time on the adverse events because those are critical. And as Grace already mentioned, enzalutamide, each of these androgen receptor inhibitors have hypertension as one of the possible things. Seizure risk. Now, the only one which you can consider in patients with history of seizures or risk of seizures is darolutamide. Darolutamide had the least blood-brain barrier penetration, at least from the lab. And because of that, it has translated to a much less seizure risk as compared to enzalutamide and apalutamide, although these have not been compared head-to-head, but that is. So patients with history of seizures, with high risk for seizures, were allowed on the darolutamide studies, were not allowed on the enza and apa studies. Abiraterone, of course, can cause fluid retention, cardiac disease. So cardiac disease patients do not prefer to go with the androgen receptor inhibitors rather than with abiraterone and prednisone, but otherwise a fairly easy thing to use. You do have to monitor them a little bit carefully, and you have to use it in combination with prednisone. Docetaxel, of course, can cause neutropenias, hair loss, and some neuropathy. Maximum 6 cycles were given with docetaxel in this setting. So more phase 3 trials that are coming up, and of this, AeroNote was just presented last month. And it, no surprise there, it did show that the darolutamide and androgen deprivation arm did much, much better as compared to doing androgen deprivation alone. Like we said, either combine it with enza, apa, abiraterone and prednisone, or consider darolutamide as a combination. And because of that, NCCN definitely has incorporated all these combinations into their frontline pathway for metastatic disease. With non-metastatic prostate cancer, now let's say patients had that PSA relapse, you put them on LHRH analog, and now their PSA is going up 2 years later, for instance. And you do a CAT scan, bone scan, no signs of metastases, all you're stuck with is a rising PSA. And how do you treat those patients? So that is where this non-metastatic castrate-resistant state comes in. And practical considerations, again, you should look at the PSA doubling time. That is a critical piece that will help you decide how high risk is this patient, how quickly are they going to have metastases. And here are the 3 medications that are approved: enzalutamide, apalutamide, and darolutamide. Again, if you've only put them on LHRH analog therapy and now they're progressing, you can use one of these therapies for that. And here is the metastasis-free survival, more than 3 years average, 40 months, 45 months, et cetera, depending on which study you look at. That is important to take into consideration. And the NCCN guidelines, of course, have this. Look at the rate of PSA rising. Now, all these studies were, by the way, done in patients with rapid PSA doubling time. So PSA doubling time had to be less than 9 months, 10 months or so before they could go on the study. So this is not for that very, very slow PSA rising patient. And then we will go to our case now with PSA non-metastatic castrate-resistant cancer.
I noticed you were coughing, so. We both have allergies and we both took our antihistamines this morning, so we're a little dry. So excuse me for a second here. That's right. So let's just go back to this real quick before we go to our next slide and next case. So again, to remind everybody, Abby, as well as the other RPs that we have here, have been associated with worsening hypertension or increase in blood pressure. Darolutamide, as well as APA and enzalutamide, have been associated with fatigue, but I think that would be true pretty much for all of them too. Abiraterone has been associated with adrenal insufficiency, so you tend to prescribe this together with prednisone, and anywhere from 5 to 10 milligrams daily. Has also been associated with hypokalemia, so patients might require, not everybody, so you can start them, monitor that K level. And I have patients who have done okay on 10 mex daily. I have a patient who requires 40 mex daily, so kind of titrate it based on the need. But Abby, you want to try to avoid it with patients with high CVD risk. And perhaps consider dose reduction for all of these agents too, if the burden of adverse effects is just too heavy. And you want to consider avoiding ENZA and APA for patients with seizure disorder or those at high risk for seizure activity. Cognitive impairment has been mostly associated with ENSA, although I've seen it in some of the other agents too. And consider potential interaction with anticoagulants and your PPIs for ENZA and apalutamide. Rash has been seen for APA and usually are well managed with topical steroids as well as oral steroids for severe conditions such as hydrocortisone. APA uniquely is also associated with hypothyroidism, so monitor your TSH and T4s for these patients and consider levothyroxine supplementation as needed. Darolutamide can be continued when docetaxel and a triplet regimen has to be discontinued, so you can do that in combo with your ADT. Docetaxel, one of the most common reactions to this medication is neutropenia, and it can be as severe as grade 3 or 4, and usually occurs after the first cycle of this drug. Fatigue, again, has been largely associated with docetaxel, but usually can be seen with the other agents as well. Nausea and diarrhea can happen with dosi, so make sure that you are discharging or sending your patients home with supportive medications, your loperamide, your ondansetron as needed. And docetaxel has also been associated with peripheral neuropathy, so make sure after their first treatment and as you go on with treatment succeedingly, you're checking them for signs of neuropathy. That would be your tingling, numbness of your peripheries, pin pricking, burning, shootings, pain is what the patients might describe. So we're going to go on to our next case. The next case is CS. He's a 68-year-old Hispanic male with newly diagnosed high-risk, non-metastatic, castrate-resistant prostate cancer. Pay attention to these things because it's going to be important when we ask the question. His past medical history is significant for a traumatic brain injury, hyperlipidemia, atrial fibrillation, and GERD. When you review his medication, and very important, like Dr. Vaishampayan was sharing earlier, this patient who travels from Florida to Michigan was on ENZA. It was not caught, and they were not sure what this idiopathic seizure was from, but it was actually medication-induced. So always make time for that during your clinic visits, because a lot of the problems the patient may be having or potentially may have can be minimized just by doing a med rec alone. So he is on simvastatin, apixaban, and omeprazole. So for this patient, well, what will be the best RP or androgen receptor pathway inhibitor to consider adding to his ADT regimen when you are considering treatment intensification? Would you consider enzalutamide, darolutamide, apalutamide, or abiraterone?
I need somebody help.
I was he's giving them accolades on the sidelines there, because whoever picks the songs for these polling questions, they're actually good DJs, don't you think? They're very appropriate for the time and the intent they're being used for. So darolutamide, excellent. So darolutamide will be your drug of choice. Why? Because this patient has a TBI. So even though he does not have seizure disorder at this time, he is at very high risk for developing one. So his seizure threshold is very low, so Enza and APA will not be the best choices. Abiraterone probably is not completely wrong, probably not the best choice either. Remember, this guy has AFib, so he already has existing cardiac dysrhythmia. He has cardiovascular risk with his hyperlipidemia. So darolutamide may be the most non-toxic, most benign medication to pick among your choices here. Is this Dr. Vaishampayan already? My time goes fast. I don't know if I talk fast or...
No, very soon. Okay, so home stretch here, metastatic castrate-resistant prostate cancer, which is where patients have metastases and they are progressing on androgen deprivation therapy. So their serum testosterone is suppressed, less than 50, as we said, is the conventional, and they are showing you progression. So basic concepts, there are all kinds of medications, so most of which you may not, as urology nursing, be involved in necessarily, but at least it is important to have some background that there's chemotherapy, there is all of these oral agents, of course, but assuming that you've used up the oral agents with our treatment intensification, either in the non-metastatic castrate-resistant or metastatic castrate-sensitive therapy. Now it's time really to get those biomarker therapies. So PARP inhibitors, if you haven't already tested the patient, it is important to get that ball rolling, to start genomic testing, both on their tissue and the blood, because either one of those, if they're positive for BRCA1, BRCA2, ATM, etc., that would help you give the patient an additional option, which is the PARP inhibitors. And then there are combinations of PARP inhibitors, Abi plus niraparib. There's actually a combination pill that combines both abiraterone and the PARP inhibitor together. There's olaparib plus abiraterone, and then there is, of course, talazoparib, TALAPRO study that showed that combination was approved. So abiraterone, just to give you a sense, it is a CYP17 inhibitor. So the prednisone is not just to, icing on the cake. It actually is needed with abiraterone to help reduce the side effects of abiraterone. So what abiraterone does is it blocks androgen production at the adrenal gland and at the tumor microenvironment level. But the way it does that is by inhibiting the CYP17 enzyme, which is responsible for cholesterol to be converted to testosterone. But as you inhibit that enzyme, all that excess cholesterol gets diverted down a different pathway. So you get mineralocorticoid excess, and because of that, you're having to see all the mineralocorticoid excess effects, which is fluid retention, leg swelling, edema, or low potassium. All of those are linked in, and because of those side effects, you can get issues with people who already have cardiac disease. They can decompensate quicker. That's why in patients with cardiac disease, we prefer not to use abiraterone. And prednisone does help with a lot of those symptoms because prednisone blocks that excess ACTH and reduces the amount of mineralocorticoid that is formed. So because of that, you have to use the combination of abiraterone and prednisone. And then Enza, APA, darolutamide, of course, as I said before, those are androgen receptor pathway inhibitors, and these are their typical side effects: hypertension, seizures, myalgias, rash. And Enza and APA should not be given in patients with history or risk of seizures. This is a big whole table showing you that all of these agents have shown a median survival benefit of 3 to 4 months, whether it be chemotherapy, whether it be immunotherapy, or any of the radium-223, which is, as I said, only for bone metastases. You should be using that. It's a once-a-month IV radiation. And then PSMA lutetium, the most recent FDA approval in metastatic CRPC, which is also a radiopharmaceutical therapy given once every 6 weeks for a maximum of 6 doses, and that also can produce a response. Now, the advantage of PSMA lutetium, it doesn't have to be only bone disease. What it does have to be, though, on the PSMA PET scan, you need to see that there is PSMA avid disease, because if the disease, cancer is not taking up the PSMA, your treatment is going to be useless in that patient. Again, side effects are bone marrow suppression, dry mouth, and elevated worsening of kidney function at times. So those are the things we monitor closely before okaying the next dose and the next dose on each patient with PSMA. Plus, you need to see. Now there, the PSA response will tell you if the patient is benefiting or not. And if the patient is not benefiting, there's no reason to blindly keep going to the 6 doses of PSMA lutetium, because if you don't have the target anymore, all you're doing is inducing side effects. So just be careful, and if a couple of times you're seeing that the PSA continues to go up in leaps and bounds, wait, stop and do another scan, see if the patient is progressing, and pull them off treatment. If they're not progressing, if they're truly continuing to benefit, absolutely important to finish out the 6 doses. So other treatment sequencing, as we said, cabazitaxel is a chemotherapy post-docetaxel that we can use. The slight advantage of this medication is that it doesn't cause neuropathy. And in majority of the patients, it doesn't cause hair loss. So that is something, but it does have cytopenias, it does have diarrhea, so it's not without side effects, to say the least. Precision oncology. So precision oncology is basically looking at tumor targets or by imaging targets. So the imaging target is the PSMA expression. If you see that, then you can consider the patient for PSMA lutetium therapy. If you don't have that, or even otherwise, if they have any of these genomic mutations, again, that's a target that you can use PARP inhibitor therapies. Prostate cancer men with BRCA2 have more aggressive disease, and they may or may not have any family history. So the family history is not essential. Now NCCN guidelines will allow you to test every man with metastatic prostate cancer for genomic germline testing. And germline mutations were actually seen, depending on which series you look at, from like 10 to 20% even. So a large proportion of our patients can get this therapy if we test them in a timely fashion. And these are the different other genomic targets that we look at, which is mismatch repair. MSI high is very small proportion, 1% or less, but that patient population is very sensitive to immune checkpoint therapy. So pembrolizumab is the typical medication that is approved in that setting. Other CDK12, also PARP inhibitor or pembrolizumab, and then tumor mutation burden. If the mutation burden is high, that is another reason why patients may be more sensitive. Typically, though, in the average prostate cancer patient, unless they have MSI high or high tumor mutation burden, any immune checkpoint inhibitors have not been shown to be effective. So here is the studies. I'm going to skip through that so we have some time for discussion and questions. But bottom line, the PARP inhibitors, BRCA1, BRCA2 patients have shown the most benefit with PARP inhibitor therapy. It's an oral agent, and there are a number of them. There's olaparib, there's rucaparib, but there's daraparib and talazoparib. So there are 4 different PARP inhibitors approved in different settings, but BRCA1, BRCA2 are the patients who benefit. And no matter which one you use, there is a risk of anemia, bone marrow suppression. Those are the things that we need to monitor patients for closely when we give them PARP inhibitors. Besides that, there could be some GI side effects, etc., but really, the bone marrow suppression and drop in blood counts, just because it's a pill doesn't mean there aren't side effects. There clearly are. And here is the different evidence, but bottom line, suffice it to say, if you use the PARP inhibitors in the BRCA1, BRCA2 patients, it is important to monitor them. And then here is the PSMA PET scan. We saw that before, that it can show you areas that light up on the PSMA PET scan, and you can use that as a target to give this radiation therapy, the lutetium-177, which has shown to be effective. And this is the registrational VISION trial that showed, and these were all patients who did not have any other options, post-docetaxel, post-chemotherapy, post-hormone therapy patients who had a benefit in terms of overall survival. Median survival benefit was about 3.5 to 4 months. Again, I discussed the risks already, and this is the PSMA-4 trial. So clearly, when it showed efficacy in the advanced setting after chemotherapy, we of course wanted to see if we even need to treat our patients with chemotherapy. Why not give the PSMA lutetium before chemotherapy when patients are progressing on an oral agent like Abienza, et cetera? And that's where the PSMA-4 trial, but this is not FDA approved in this setting. Currently, FDA approval for PSMA lutetium is only after chemotherapy treatment. But this study was randomizing patients to second oral agent as compared to lutetium PSMA, and it did improve the progression-free survival. The reason we are waiting and we have not yet received FDA approval is overall survival benefit has not been shown as yet. And maybe it's not adequate follow-up as yet, but there is clearly a benefit there of a median of at least 6-7 months or so, 6-7 months, in terms of progression-free survival. So quality of life also has been shown to be better in those patients, and they had prolonged control of the disease, so time to chemotherapy, et cetera, was much more delayed. And then we'll end with neuroendocrine prostate cancer, which is one of the very resistant, advanced, rapidly progressing disease. Now, that disease is something where we use carboplatin etoposide, so platinum-based chemotherapy. One thing to keep in mind, though, if the patient's PSA is low, so 0.1, 0.2, but the patient themselves look miserable, if they are not doing well, fatigued, losing weight, loss of appetite, those are your clues to think about, hey, wait a minute, something is going on here. Even if the PSA is looking fabulous, there is potentially neuroendocrine disease, and frequently if you do a scan, you will find that those are the patients that have a liver full of metastases. So keep that in mind, because the PSA is very deceptive in those patients. If the patient is not doing well, do the scan, because there may be signs of neuroendocrine disease, because that does not express PSA. So because of that, the PSA is low, but the disease is going crazy. And that's where maybe immune checkpoint therapy will have a role, and we are currently studying it in a study of lenvatinib and pembrolizumab, and if that shows efficacy, which there is preliminary data that it is looking effective, chances are we will get immune checkpoint therapy in neuroendocrine disease. And with that, I'm going to turn it over to Grace to do the next case.
Back up a little bit before we go to our last, to our last case here. So just a review in summary of what Dr. Vaishampayan said. So your PARP inhibitors have been associated with cytopenia, so make sure you're providing supportive care, perhaps transfusions if necessary. Consider dose modifications as needed. It can induce fatigue, which can be more severe than your RPs or your androgen receptor inhibitors. So be mindful of that. And there's also a risk for development of myelodysplastic syndrome or acute myeloid leukemia. So monitor your CBC and diffs for these patients. For Lu-PSMA, it's typically well tolerated. There's low-grade AEs associated with them. Fatigue is also seen with this treatment, so supportive care is important. Myelosuppression has been seen, so your counts have a tendency to drop, so make sure you're monitoring them and dose modify if needed. Xerostomia, or dryness of the mouth, has been seen in Lu-PSMA 617. So make sure you're educating your patient with good oral hygiene. Chewing sugarless gum might be helpful to treat that condition. Sucking on ice chips, cold water rinses, and the use of artificial saliva can be considered. And of course, because this is involving radiation safety should be a primal point of your education with this patient. Encourage them to hydrate very well and to advise them to void frequently. So again, some safety considerations to consider when treating certain types of patients. Your older patients, they tend to be older in the setting of prostate cancer, like Dr. Vaishampayan said, and so typically they have more comorbid conditions than your younger patients, especially if it's in the earlier setting of the disease. And I remember giving a talk with a geriatric oncologist once, and her words stuck to my mind: old does not equal frail. So there are tools you can actually use if you're not sure. Your 60-year-old patient is not necessarily going to be less frail as your 80-year-old patient all of the time. So don't discount patients just based on their age. You want to make sure you control CVD risk factors or cardiovascular disease risk factors. Again, this is more commonly the cause of demise of patients with prostate cancer, not the cancer in itself. Androgen deprivation and hormonal treatments have an increased risk for diabetes, metabolic syndrome, hypertension, and cardiovascular disease. So make sure you're monitoring those other conditions, those numbers as well. Managing cytopenias would be something to consider. When is blood transfusion typically indicated? Usually it's at grade 3 levels, which is your hemoglobin of under 8. And when do you cut down on the dose or consider discontinuation? So definitely if you're in your grade 2, which is less than between a range of 8 to 10, that's when you want to start thinking, because you don't want to get to the point of having to transfuse this patient. In the VISION study of loop PSMA, hematologic toxicities were found to actually be reversible. Leukopenia was seen in up to 40% of the patients, and thrombocytopenia in up to 70%. PARP inhibitors are also associated with hematologic toxicity, particularly anemia, so still be watching those blood counts for those patients. Bone mets, you want to be promoting their bone health too, preventing skeletal events. So usually these patients are treated with denosumab or zoledronic acid for this condition. So back to our case. This is actually still our case. Case 2, unfortunately, CS developed rising PSAs within 6 months, with 6-month doubling while on the combination of ADT and RP. His PMSA PET scan showed a new lesion on his liver, which was biopsied and was consistent with metastasis of the prostate adeno to that organ, unfortunately. He underwent germline and somatic genetic analysis that showed no actionable mutations. His treatment regimen was changed to ADT and a combination of docetaxel chemotherapy at that point. Unfortunately, he developed grade 3 peripheral sensory neuropathy after 3 cycles of docetaxel. What will be your best next treatment to consider adding to your ADT at this point? So number 1, do you consider adding loop PSMA? Do you consider adding abiraterone? Do you consider adding olaparib? Or do you consider adding cabazitaxel? We'll give you some time to think about that and put in your answers. Pressure. All right. Yep, you got that right. And why is that? Why are we going to do PSMA instead of these other things? So he's already progressed on your RPs, so 2 probably is not the best choice. He has had no actionable mutations. If you remember from our genetic analysis, olaparib will not be your best choice either. And he already had grade 3 neuropathy. Cabazitaxel, another chemo agent, is also associated with peripheral neuropathy, so you're probably not going to have a patient who will tolerate this drug after docetaxel.
Well, I hope you enjoyed that show. I told you it was going to be a long one, but I think there was a lot of great valuable information. Now, in order to get your contact hours, you just need to go to our website, UroNurse.com, and you'll see a yellow box, kind of the same color as you see on my name tag, a button that you can push. It'll tell you to get your contacts. It'll bring you to the website. It's going to make you take a little pre-quiz, and then it'll show you the show, but you don't have to watch it. You can skip through until you get to the next button. And then it'll bring up to your post questions. And then once you answer those, as long as you pass the test, you'll be able to get your contact hours for free. All right. Be sure to join us again next week for more at UroNurse.com.